Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
And I'm going to be giving you, okay. So welcome everybody in tonight's class. And tonight's class, we're going to be talking about the blood supply of the pelvis, which is confusing, difficult to remember. And I'll try to make it very, very easy and simple for you, logical, and a lot more fun than what it is, reading from the book. Now, the thing that you all like the most, the questions which come from anatomy. And why I have included in the last lectures, because I think I've included every part of it in my anatomy lectures up till now. So anatomy of pelvic ureter, the relationship of ureter, the possible sites of injury, the way in which the injuries can be prevented. It's not only there in my answer bank, it's also profusely given in the lecture that I took on ureter and bladder. The next about major blood vessels supplying the pelvis, I'm going to be taking it right now. This question has been recently asked in October. I'm sorry, maybe, October or the session right before that. This question has been asked about the arterial supply, which is very, very important. That makes it even more important because it's a recent question. Clinical significance of the collateral solution, obviously circulation of the pelvis with emphasis on internal iliac artery ligation. Enumerate the complications of internal iliac artery ligation. We've going to be covering all these aspects, and we've already covered most of these. Retroperitoneal spaces, boundaries. I think I've spoken enough regarding the pelvis and its relationships. I spoke about the deep perineal pouch, superficial perineal pouch, ischioretial fossa, anatomy of anterior abdominal wall, ureteric injuries, uterosacral ligament, all these things, especially see ureter has come so many times, right? And then of course the anterior posterior division of internal iliac we're going to be talking about in tonight's class, and the indications of internal iliac ligation we have covered it, and we're going to be covering it in the lecture on PPH, right? So the surgical procedures of controlling PPH we've talked about internal iliac artery ligation, correct? And obviously the complications and everything is there. Then see how many times pelvic ureter has come. That is the reason why in surgical anatomy of urinary bladder, prevent urinary bladder injury, rectify the injury, and then the lymphatic drainage. So we've spoken in detail. There was a class that I took on just lymphatic drainage alone. So I think by now I've included and finished most of the part of anatomy lectures. And tonight is the last class on anatomy, and we're going to be talking about the blood supply of the pelvis. So watch out close. It's very, very simple, very easy, and make it a lot of fun for you people so that you remember it and you're able to produce it properly in the exam without having to, go through a lot of mugging. The anatomy, and especially the anatomy that you have to remember, it's not very difficult. And if you just go through the lectures that I have given you once, you'll be so well oriented with these spaces, which I used to find very difficult to remember. And tonight, the second most important thing, which I used to find very bad, in remembering, ureter was fine, bladder was okay. Remembering these blood vessels and their, and nerve supplies was horrible. So I've tried to make that simple in the last lecture, the nerve supply. And now I have this blood supply. I'm going to be making a lot of fun. So let's start with the first things first. You have this as the most important slide, because here you can see this is the abdominal aorta. It's called abdominal aorta because it's finally going to supply now the abdomen and the pelvis. Here, over at this point in time, it divides into two, right? So this is at the level of L4. It divides at the level of two common iliac arteries, the right common iliac artery, the left common iliac artery. And why do we call it the common iliac artery? Because after that, they again branch out into two, external iliac artery, this one, and the internal iliac artery. And we are more bothered about internal iliac artery. Can any one of you just let me know, why don't we talk about external iliac artery? Why do we talk about internal iliac artery all the time? So in your chat boxes, guys, come on, everybody, quickly write down, why are we interested in talking about the internal iliac artery? Why don't we talk about the external iliac artery? Where do I have my favorite students? Where are they? So I can see 15 online, but I don't see any answer coming up, and nobody's even typing. So come on, guys, quickly. Yes, very good. So it's very, very fast. Because why do we talk about the internal iliac artery? Because external iliac artery, it supplies everything externally. So it supplies mostly the, the muscles of the anterior abdominal wall, some of them, muscles in the thigh, then it goes and, continues as a femoral artery. So it goes, supplies mostly the external, areas. So it supplies the skin or the muscles or the joints and the ligaments. And it doesn't supply the internal pelvic organs, which we are mostly bothered about, which is why we are concentrating on the internal iliac artery. Correct? That was the thing I wanted to tell you. And why don't we talk about veins so much is because most of the veins, they are after the name of the arteries. Correct? And it's the arteries which bleed the more. It's the arteries which supply. Veins just take the blood back. So that's the reason why we do not talk about venous supply. We always talk about the arterial supply of the pelvis. Correct? Still, if you want to really know, this is the most important vein in the abdomen, the inferior vena cava, made from the common iliac veins, both from here and right and the left common iliac veins, of course, coming from the internal. And see, the name is also after the arteries only. If you remember the arteries, you automatically remember the veins. This is external iliac vein, this is the internal iliac vein, and look at the caliber of this. You know why this is very, very important? This aspect, this whole part is very important. I'll tell you the one very important applied anatomy of this particular part. Why over here, aorta is important, definitely, but equally important is inferior vena. Okay, fine, I'll give you two. Give me two reasons why inferior vena cava over here is very, very important. Come on, guys. One reason you already know, one is obstetric reason. The other one is a gynae reason. Can you quickly tell me? Okay, very good, Sarah. Can you tell me, please, the reason why inferior vena cava is very important? One, I'm sure you all will be able to tell me. It's about the gravid uterus, right? Okay, all right. Okay, that's okay. I'll take that as well. Anything else? Inferior vena cava I'm talking about, not aortic. Not about aorta. Aorta is definitely very important, and I'm going to be telling the entire class is about aorta and its branches. But why is inferior vena cava very important? Apart from, of course, the gravid uterus, kind of putting pressure over it, and it's decreasing the cardiac output. Supine, hypotension, that goes with what I'm saying already, right? Any gynae reason for why inferior vena cava is very, very important? Deep vein thrombosis. Well, we'll talk about the leg veins in that matter, not about the inferior cava. That's too large a vein, for calling it involved in DVT. We'll talk about the leg veins there. Anything else? Anything else, guys? So let me see how many more have joined in. Okay, there's still 15. Okay. I'll tell you what, guys. What happens is that when you're putting the first port laparoscopically, okay, when you put the first port in, especially in thin individuals, sometimes you hit the external iliac artery. Mostly, if you do not hit that, you hit the vein, the external iliac vein, or the internal iliac vein. If you go a little more lateral, rather than just screwing it absolutely in middle, sometimes your hand goes like this. And the right-handed people, they usually go like this in the abdomen, right? Can you see it? Like this in the abdomen. So instead of going like this, they go like a little bit like this. So this is where you hit mostly one of the branches that form the external iliac vein or the internal iliac vein, of which join to form the inferior vena cava, that is the common iliac vein. Sometimes you directly hit the common iliac vein also. Okay, because superficial is actually the aorta, that's true. And right common iliac artery is very, very easily hit. More than that, external iliac artery is hit. But sometimes even this external iliac vein can also be hit. All right, so this is a very important applied anatomy of this particular part. Now, before I get on to the most important internal iliac artery and its branches, which is the reason why everybody is here, I'm sure, to do it quick and easy. Very important is the ovarian arteries. Last time also I'll tell you in every lecture, because that does not decrease the importance of ovarian artery. It still remains the same. Ovarian arteries are very, very important arteries. Why? Because ovarian arteries, they are supposed to be the direct branches of abdominal aorta. So a lot of respect has to be given to the ovarian arteries. That being said, which is the most important pedicle, in which the ovarian arteries they transcend, which is the very important pedicle while doing hysterectomy, which is that pedicle we have to be very, very sure of when you are, you should be scared of ovarian arteries. Which is that pedicle? I've spoken about it so many times. I'm sure the answers, I need quick answers from everybody. So only 2 people. Now there are 19, 20 people. I don't know about online and I don't know about in the class, but I don't know what they're doing being online, but yes. Come on, tell me, guys. Infundibular pelvic, yes. So it's when you are removing the ovary, right? And you put a clamp on the infundibulopelvic ligament. Be very sure of ligating it properly. I remember our consultants being super strict with us. We used to think it's such a small pedicle, ovary was so small, pedicle is so small, it's just little lateral, I understand. But I never used to understand why they're so scared of this pedicle. They used to tie it twice, you know. And even when I was doing my private practice and my other, you know, when I went on to this clinical scenario, every time I would, you know, somebody would come to assist me, they will make sure that it's ligated twice. So now the thing is, obviously, of course, now even I do it twice, because now I respect that artery so much that it's a twig from a very, very important artery called the abdominal aorta. Once it starts bleeding, it is not going to stop, because the thrust of the force, the pressure of the force is so high. That's because it's a direct branch of abdominal aorta. It's not going to stop. It can cause intractable bleeding, and it can cause a very big hematoma. So always have a lot of respect. Do not after tying the ligature, do not strain the ligature too much. Do not pull on that ligature too much. Do not just cut them short and let them be. Okay, just make sure that the pedicle is a little longer, you know, so that your tie is proper and fixed. It doesn't slip out. Sometimes you tie it very tight, but the ligature slips out. It happens. Just imagine any loose end to which you are tying something, that end, if it's slightly pulled anywhere, and if the ligature is slightly, you know, slightly loose, it will easily break free, and the the knot is going to just dump inside the abdomen, and the pedicle is open. Nightmarish. I'm going to be taking up, hopefully very soon, one class on abdominal hysterectomy, telling you each and every step properly with pedicle. I've got a very beautiful video recorded from my own OT. So I would love to share that video with you. And I would want my students to, learn it through, direct, proper teaching, especially the bookish way. We do this hysterectomy exactly as it's written, it's given in the book. No ifs and buts. Beautiful surgery it is, recorded also pretty well. I hope I'm able to share it with you probably in the next class. And then we'll see how we plan the next classes to come. So ovarian artery, very, very important. So before I get on to the internal iliac artery, I wanted to talk a little bit about the ovarian artery. And, what else should I say? We've already spoken about the infundibulopelvic ligament. We've talked about the being a direct branch of the aorta, abdominal aorta. Here it is. At the level of L1, it gives away this branch, and it's distal to the renal arteries. That's very, very important, because even renal arteries are direct branches. And you give the branches, and it anastomoses. It anastomoses with the uterine artery. That's also going to come very soon in the lecture too.